Respiratory distress in newborn. Clinical features. Respiratory rate is increased more than 60 breaths per minute. Normal newborn respiratory rate is 40 to 60 breaths per minute. It is called increased when it is more than 60. Chest retraction. It is due to involvement of accessory respiratory muscles. Severe hypoxia is seen in severe cases. Manifest as central cyanosis, involves mucosa as well. Grunting, expiration against a partially closed glottis, prevents airway alveolar collapse. Monitoring of respiratory distress. Scoring system. So first you have what is called Silverman-Anderson score, and it is used for preterm babies only. So you have your score 0, 1 and 2. So we will see the score 0, and the criteria are 5. First is upper chest restriction, second is lower chest restriction, third is nasal flaring, and fourth is xiphoid retractions, and fifth is grunting. So score 0 is synchronized respiration between chest and abdomen, and lower chest retraction is not seen, nasal flaring is not seen, xiphoid retraction is not seen, and grunting is not present. So we are trying to keep the score as low as possible so we can say that it's a mild respiratory distress. So this score 0 is good. Then we see the maximum score 2. So seesaw respiration, chest retracts, abdomen expands during expiration. That is seesaw. Your abdomen is expanding during expiration. That is number 2 score. That is very severe. Then where there is severe lower chest retraction, there is severe nasal flaring, there is severe xiphoid retractions, and there is the grunting is even audible without a stethoscope. So that is score 2, that is the severest, the maximum score. The score is more, so there is more respiratory distress. So you remember score 0 and you remember score 2. And this in between is score 1, so just read it, that upper chest retraction, lag, chest lags behind abdomen during inspiration. Everything else is mild. Grunting can be heard with stethoscope. So your score less than 5 is mild, and more than 7 is severe, and in between is moderate. Downey's score, which is used for term and preterm babies. Mnemonic for this criteria of Downey's score for term and preterm babies is CRARG. So what is CRARG? Downey's score. C for cyanosis, R for respiratory rate, A for air entry, R for retractions, and G for grunting. So again score is 0, 1, 2. Let's see 0 first. 0 is, now here you want the score to be as minimum as possible. So cyanosis 0, not present. Respiratory rate less than 60, which is normal, then 0. Air entry bilateral equal and normal, then 0. Retractions not present, then 0. Grunting not heard, then 0. But 2 is the most severe. So cyanosis is present even with O2 support, that is FiO2 more than 40%. Then the score is 2. Then if the respiratory rate is more than 80, then the score is 2. If air entry is severely decreased, then the score is 2. If retractions is um, severely seen, then the score is 2. And then the grunting is audible without stethoscope, then the score is 2. In between that is score 1. So cyanosis in score 1 is present at room air. Respiratory rate is between 60 to 80. Air entry is decreased, retractions are mild, and grunting is audible with stethoscope. So here less than 3 is mild and more than 6 is severe, which is one score lower than your Silver-Anderson score. Causes of respiratory distress. Respiratory distress onset within 6 hours of birth or onset anytime after birth. So within the 6 hours, distress is called transient tachypnea of newborn, which is the most common overall. And respiratory distress syndrome, Meconium aspiration syndrome, also happens within 6 hours. After then, any other time is pneumonia, pneumothorax, anomalies of lung development. Transient tachypnea of newborn, also known as wet lung syndrome, most commonly seen in term neonates. Neonates delivered by lower segment cesarean section. Pathogenesis, term neonates, adequate stimulation and compression at birth canal, delayed clearance of the lung fluids, and because of that, this happens. Chest x-ray finding, you will see perihilar radio opaque streaks. Fluid and hilum of lung moves into bronchovascular structures. White streaks on X-ray, also known as sunburst appearance. Fluid in interlobar fissure. Wet lung syndrome is your transient tachypnea of newborns. Happens in term babies due to which are birthed by C-section because there is no enough clearage of the fluids. What is your management? It is supportive O2 management as it is sufficient because it's transient. Improvement is seen within 2 to 3 days. Respiratory distress syndrome, also known as hyaline membrane disease, most commonly seen in preterm babies, that is less than 34 weeks, and born to mothers who haven't received antenatal steroids, which were most commonly used is dexamethasone. Infants of diabetic mother can also have RDS, that is hyaline membrane respiratory distress. Pathogenesis, preterm less than 34 weeks delivery to a mother who hasn't received steroids dexamethasone, infants of a diabetic mother which has increased insulin. Both will cause decrease surfactant. So it will increase surface tension and the alveolar collapse and respiratory distress will happen. Note, surfactant keeps alveoli open by decreasing surface tension on its lining. Histology, eosinophilic substances in lung tissues which resembles hyaline. Chest x-ray, whiteout appearance, ground glass appearance due to collapsed alveoli, no air entry. Air bronchogram sign due to open airway tract. Management. So the severity is assessed based on Silverman-Anderson score. We remember mild is less than 5, moderate is more than 7. Sorry, severe is more than 7. So for mild and moderate, what you do is CPAP and PPAP. Sorry, PEEP. CPAP and PEEP. So CPAP is continuous positive pressure, airway pressure, and PEEP is positive end expiratory pressure of 5 to 7 milliliter of water, which is maintained. It will keep the alveoli open. And in moderate to severe, you give surfactant replacement therapy, and in severe, you give mechanical ventilation. Types of surfactant for surfactant replacement therapy. You have natural and you have recombinant. For natural, you have Biractant, bovine, and Poractant from pigs, and recombinant synthetic is given with SPB. Administration of surfactant replacement therapy is by endotracheal. Technique is endotracheal tube, and they have a mnemonic for it, ensure. So how do you do it? Intubation, then surfactant, and then extubation. Ensure. Earlier synthetic surfactants leaked SPB and hence decreased efficacy. Surfactant tracheal catheter. STC is less invasive. Endotracheal catheter is used. Then you have your Meconium aspiration syndrome. Pathogenesis, postterm baby, that is more than 42 weeks, or IOGR baby. Stress, then meconium expulsion before birth itself. Then there is an aspiration of meconium stained liquor, MSL. Consequences of meconium aspiration syndrome. Atelectasis due to complete obstruction of airway. Air trapping due to inability to expire air in partial obstruction. Hyperinflation of lung, obstructive emphysema. Chemical pneumonitis, inflammatory response to meconium, inactivation of surfactant, impaired gas exchange, hypoxia, hypercapnia, chronic pulmonary vasoconstriction, and this will cause persistent primary pulmonary hypertension. It is called PPHN, persistent pulmonary hypertension, which happens in meconium aspiration syndrome due to chemical pneumonitis. Chest X-ray findings, infiltrates in lung fields seen in chemical pneumonitis. Here you can see small chest X-ray infiltrates. Diagnosis, meconium aspiration syndrome is diagnosed by exclusion and with history of meconium stained liquor. Management, supportive management is done by O2 inhalation, CPAP, mechanical ventilation in severe cases, inhale nitric oxide, pulmonary vasodilator to treat persistent pulmonary hypertension. Inhale nitric oxide. Congenital diaphragmatic hernia. So, pathogenesis, anatomical defect in diaphragm, clinical features is respiratory distress. It is due to compression of lung in utero due to development of movement of intestine in mediastinum, pulmonary hypoplasia. So this is type of diaphragmatic hernia. The diagram here shows the spine and the diaphragm. Number 1 is Bostelek, most common. It is posterolateral, Bostelek. And number 2 is Morgagni, which is anteromedial. So Morgagni and Bostelek. Now, mediastinal shift, that is how heart sound is heard on the right side. It has a sunken scaphoid abdomen. Congenital diaphragmatic hernia, absent diaphragm shadow, and you can see intestinal air shadow in the lung space. So mediastinal shift will happen, heart sound will be heard on the right side, and the abdomen will be sunken or scaphoid. Investigation, ultrasound antenatal, chest x-ray postnatal, intestinal air shadows, airfield bubble shaped shadows due to bowel, absent diaphragm shadows on affected side. Management of congenital diaphragmatic hernia. If the baby does not cry at birth, then resuscitation. And you cannot give positive pressure ventilation in them. And if baby cries at birth, then medical management in the first 48 hours. Intestinal decompression via nasogastric tube to decrease lung compression, and mechanical ventilation via endotracheal tube to increase lung expansion. After 48 hours, you do surgical management, that is hernia repair. Contraindication. So it is an absolute contraindication for bag and mask ventilation. Forceful entry of air in the esophagus, inflammation of bowel loops, further compression of lungs. So instead of the trachea, the air is going in the esophagus. Prognostic factors of congenital diaphragmatic hernia, antenatal and postnatal. Antenatal ultrasound, you see lung head ratio less than 1 is bad prognosis. Unaffected lung to be is considered. Presence of liver in thorax is bad prognosis. This is the antenatal factors, lung head ratio and liver in the chest. Postnatal. What is the postnatal? If it has persistent pulmonary hypertension, then it is a bad prognosis. And onset of respiratory distress within the first 24 hours is also a bad prognosis. We'll see neonatal jaundice in the next video.